So, dear Chairman, thank you for this nice introduction. I'm not Michael Lesotel, I'm Patrick Kambakamba, one of the senior residents in Zurich. But Michael Lesotel is here to support me. And I'm very honored to present our project about the impact of epidural analgesia on liver resection, on kidney function after liver resection. In general, we have to say that literature about epidural analgesia in liver resection is scarce. It consists most of the retrospective studies, and they investigate outcomes such as postoperative analgetic potential, postoperative hospital stay, and coagulopathy. Nevertheless, the outcomes are very heterogeneous. All these studies agree in one point, that epidural analgesia by sympatholytical effect has a significant impact on hemodynamics and causes increased hypotension, increased use of vasopressors, fluids, and colloids. Liver surgery itself, it's a challenging procedure, hemodynamically challenging procedure for the patient. We use strategies to reduce the blood loss, such as inflow occlusion and lowering the CVP by using nitroglycerin and fluid restriction. Therefore, for this study, we postulate that the cumulative effect of the strategies for lowering the CVP plus the sympatholytical effect of an EDA and counteracting by vasopressor, the vasoconstriction of the vas efferents in the kidney, may exhaust the autoregulative capacity of the kidney and increase acute kidney injury. So the objective was pretty clear, is if liver resection in addition with epidural analgesia causes acute kidney injury. For this purpose, we analyzed our HBB database, including all liver resection undergoing at the University Hospital in Zurich from 2002 to 2012. We included major and minor liver resection. Exclusion criteria were cirrhotic patients, intraoperative EDA failure. In order to keep the population homogeneous, we excluded combined resections such as combined Whipple's, colon, or gastrectomies. Further, we excluded confounders of kidney injury, such as other postoperative organ failure other than kidney, preoperative sepsis, or total vascular exclusion. After excluding 324 patients out of the database because of the just mentioned exclusion criteria, we ended up with 829 patients. Major and minor liver resections were equally distributed. And of note, EDA was used in 70% of the patients, and this is the standard of care in Zurich. Postoperative adverse events associated with the EDA occurred in 34%. The most common adverse event was hypertension with a need for treatment. And the EDA failure, which was defined in this study as stop of EDA due to one of these adverse events, occurred in 4%. EDA had a satisfying analgetic potential in our study, so the opioid use could be significantly reduced from 94% in patients without EDA to 24% for patients with EDA. Using the globally accepted ICIN criteria for acute kidney injury, namely the creatinine increase of 26 micromole within 48 hours after surgery, we had overall incidence in our population of 8% of acute kidney injury. And now what does this mean, acute kidney injury? Patients with acute kidney injury, according to these criteria, had significantly longer ICU stay, significantly longer hospital stay, and showed significantly increased morbidity and mortality. Several risk factors for acute kidney injury have been already described in literature for liver resections. Interesting, most of these risk factors were significantly associated with acute kidney injury in our population. The question that remains is EDA a risk factor for acute kidney injury? This can be answered with the next slide. In this population, the use of EDA significantly increased the incidence of acute kidney injury from 4 to 10%. And multivariate analysis showed that additionally to chronic kidney disease, blood transfusion, age, and EDA was an independent risk factor of acute kidney injury in liver for patients undergoing liver resection. And of note, it's the only influenceable predictive parameter which we have here. In order to validate our findings, what we performed was an internal tenfold cross-validation. We randomly calculated 10 populations out of the 829 and found that EDA remained a significant predictive factor for acute kidney injury and liver resection. So the question was, can we specify this a little bit? Can we find patients who are more prone to acute kidney injury after liver resection? And we separated, made some subgroup analysis for minor and major resections. And we found that EDA did not increase the incidence of acute kidney injury for minor resection, C5 and 3%. But on the other hand, it had a significant impact on acute kidney incidence of acute kidney injury in major resections from 5 to 14%. Therefore, we summarize that acute kidney injury significantly increased morbidity and mortality. This is the first description of the EDA as a risk factor for acute kidney injury for patients undergoing liver resection. And EDA did not increase the risk for acute kidney injury in minor resection, but had a significant impact in major liver resection. Thank you for your attention.